Welcome everybody and thank you for joining. So this is the second of our educational workshops for 2025. This is accompanying our proficiency test, which is open today, which is PDL1 clone SP263 in non-small cell lung cancer. And so I'm going to hand the microphone over to Corrado and Adelina to take us through this, to give you some hints and insights into scoring or assessing PDL1 that will hopefully help your participation in the proficiency test. Thanks very much.
Thank you, Sarah. And welcome everybody. This is our timetable. We thought we could, how do I get the pointer here? No, use pointer. A laser pointer, very good. So we thought we should do a brief workshop on interpretation. This is now what is happening with all our interpretative schemes to just refresh everybody and to spark some discussion as well, and then see whether these will make an impact on the way we all score cases. So we'll kind of hopefully do this in about 30 minutes, and the workshop should be interactive. And so we prepared a lot of case studies, well, Adelina has, and then we'll have polling to actually see how people can interpret the shots, the screenshots. We'll aim to close the workshop on the hour. There'll be a small but significant amount of question and answers time at the end, if we keep time. Okay, so...
sorry, I don't think you are sharing your screen.
I'm not sharing?
No.
Okay, I'll do... so everybody else can see me. I can see our screen shared in Hannah's...
See it.
Can you see it?
I can see the screen.
Yeah. Simona, maybe you should log back in. Maybe something wrong with the login. Okay, so non-small cell lung cancer. In reality, the treatment options for non-small cell lung cancer, and please understand these are a little bit of oversimplifications, depends on the stage of the disease, because lower stage disease, stage 1 and 2, are primarily treated by removal, by surgery, plus or minus adjuvant chemotherapy and all these type of things, and radiotherapy. What stages 3 and 4 are treated by primary chemotherapy, in other words, neoadjuvant treatments. And PD-L1 is important in all stages, but is more important in the advanced stages. So in these advanced stages, the discrimination is whether the tumor has mutation drivers that are treatable. Because if there are treatable mutation drivers, that's kind of the target of therapy that we need to give. With some exceptions again, and please understand this is a field in evolution, because unfortunately none of these treatments is really successful. So sooner or later people recur, etc. So there are now combinations of immuno-oncology with targeted therapy that are tested. But once you exhausted targeted therapy, because the tumor starts to get resistant to those treatments and there is progression, then you have an opening for immuno-oncology. Of course, if there are no mutation drivers that we could identify and therefore no adequate targeted treatment, the immuno-oncology is on the table there. And then the question is going to be, do we give it as first-line monotherapy, or do we give it as first-line in combination with chemotherapy and so on? And that's where patient selection is going to be important. Okay, so I have a few slides here that say, for instance, why? Why do we want to use immune checkpoint therapy? And I wanted just to point out that lung cancer is not a nice disease. So have a look at these dots. So this dot is how many people die or how many people survive. And you can see that later stage disease is not really amenable to life. This is 1 year survival. And if you look at 5 year survival, essentially it's game over. So this is a serious disease where the therapy will impact significantly. And when you look at how well we've been improving survival along the decades, until this is the last decade, when we go to the targeted treatments, we haven't really made much impact here. Yeah. So now with the targeted treatment, anti-GFR, anti-ALK, etc., there is a slightly better prognosis for those that.
Plus the neoadjuvant approach.
Yeah. Okay, so on these settings, you see these immune checkpoint modulators, they made a quantum difference between chemotherapy only and chemotherapy plus, or just for instance, in this case, nivolumab. So you remember all these trials have little kind of names. So the trials of pembrolizumab are called Keynote. The trial of nivolumab, which is an anti-PD-1 drug, is called Checkmate. These are two anti-PD-1 drugs. And you see that the improvements in progression-free survival is significant, and that what kept everybody very excited about these things. Doesn't come with no consequences. First of all, it's an expensive treatment, and secondly, there are a lot of side effects, which we know about. Is about autoimmune diseases and these kind of things. So let's give a little bit of background on the immune checkpoint inhibition. Nobel Prize in 2018, these two gentlemen that looked at the use of the modulation of immunocheckpoints for targeting, for treatment of cancer. And Professor Allison worked on CTL4, that is a facilitator of the immune response, and Professor Onyo worked on PD-1, which is an inhibitor of the immune response. So what are these things? These are the so-called second signal responses. So we learned about the two signal responses, immune responses, when we unveiled the antibody-mediated immunity, and we realized that in order to produce antibodies, we didn't need only one signal, which was the antigen presentation. We need a second switch to initiate. So the T-cell response works exactly the same. So instead of the B-cell receptor, which is essentially the surface immunoglobulin, you have the T-cell receptor. There is still a presentation of the antigen, and then there needs to be a second switch, because otherwise nothing starts. And the second switches can be promoters of the immune response or inhibitors. Yeah. So why do we have inhibitory switches? I think we can talk about it in a moment. Okay, so as it turned out to be that, I think I skipped though. No, as it turned out to be that these immune checkpoint regulators are large numbers of surface molecules. So there are receptors, they're here, and there are ligands, but the ligands are also membrane bound. So these are systems where cells need to come in close contact with each other. And you can see they are promiscuous. One ligand or one receptor can be attacked or stimulated by different type of ligands, and vice versa. And we are not entirely clear, because I think the same receptor can promote or inhibit a function in certain circumstances. Anyway, once the second signal is activated, then there is an immune response. And you see how complicated this web is. These are more recent maps. There are a lot of these signals. And the pharmaceutical companies are very excited about this, because a lot of these interactions are druggable. Druggable interactions means business, and so there is a huge amount of effort to try and modulate these interactions to see whether some of these interactions are actually effective in treating something. And there is a lot of focus on cancer, but not necessarily only on cancer. These are also used for autoimmune diseases. There is a wide range of applications. Okay, so this is a kind of a more focused diagram between an antigen-presenting cell and a T cell. And this is the T cell receptor, the two dimer, and this is the surface, the antigen recognition side, and this is the major histocompatibility complex that presents the antigen to the T cell that recognizes it. There are accessory molecules you can see here, all these things. And then this is the first signal, and these obviously these are receptors, these are phosphorylating things, etc., etc. So now I either enhance these using, for instance, CTLA-4, which has this ligand B7-1 on the surface of antigen-presenting cells or other cells, and this one will amplify this process, or I dephosphorylate the T cell receptor by activating things like, for instance, PD-1. And in the grand scheme of things, what happens is this is the antigen-presenting cell. This is the T cell that is competent, and this is the tumor cell. Well, the competent T cell can be inhibited either by suppressor macrophages, those M1, you remember M1, M2 macrophages?
And all sorts of other antigen presenter cells in the tumor environment. Yeah,
so it can either, for some reason, suppress this response, or cancer cells can express PD-L1 and switch off the T cell that bothers them, So why? Because PD-L1 is another molecule on the repertoire, on the shelf of your genome, and you could express it by chance, and then it becomes useful, and you like that.
And we need to think about all the complex other processes that are happening around that influence this kind of reaction with the inflammation.
Yeah. And these actually, if you think about it more widely, you understand why even when we select patients, the response is not 100%, because there are lots of other compounding factors to determine whether cancer responds or not to this. And so these interactions can be interfere with using monoclonal antibodies, humanized, that bind either PD-1, as in this case, or PD-L1. So there are kind of two ways in which you can interact it. Remember that PD-1 is not present only on T cells, it's present on other cells, and then therefore, and PD-L1 is present also on different cells. So the two type of therapy, the anti-PD-1 and the anti-PD-L1, is not quite the same, So pembrolizumab, that is anti-PD-1, will not have the same mechanism of action of atezolizumab, this anti-PD-L1. Okay, so whatever happens is that by stopping the negative inhibition, you free the T cell to become effector, and we know that the T cell mediated immune response is very powerful in cancer. In fact, it's the best cancer therapy if we could possibly understand how to make it function all the time. So that's the basis of the immune checkpoint modulation. I wanted to talk to you about T cell exhaustion, because it's a phenomenon that exists, and we know it exists in many immunological conditions, especially when there is chronic stimulation. And cancer is a chronic disease where there is chronic stimulation. And two questions, why, what is it? And then also, but why does it happen? Why do we have this mechanism? Why do we have this phenomenon? The phenomenon exists because if we continuously have effector cells that fire up, cell-mediated immune response, this is really toxic. So, you like that if you have an attack by a virus or something else, and you need to get rid of it, but you need to get rid of it within a short period of time. And if it becomes chronic, there are mechanisms to dampen this out, because it's really incompatible with life to greater extent. So, for instance, chronic viral infections will will cause exhaustion of the effector T cells. And we know that the longer you inhibit the T cell, the progressively less functions this effector T cell has, and it becomes more and more dormant. But if you break this inhibition, then it will regain function. So I think that in some of these cancer patients, there has been this chronic exhaustion of the T cells, and this immune checkpoint modulator is a chance to break down this inhibition and regain the competent T cells to be effective to tumors. Obviously, not all patients have T cell exhaustions, and not all patients are capable to have a T cell response towards the tumors, because some tumors are not immunogenic for T cells. So therefore, the need to understand how to select patients. So how do we select patients? We use the old immunohistochemistry, faithful immunohistochemistry, and we look at PD-L1 expression by the tissue. And this doesn't work anymore. And there you go. And so if you stain tumor tissue with with an anti-PD-L1 antibody, you realize that there are patterns. And some tumor tissues, there are deserts for PD-L1. They're called immune deserts. Some others seem to have an excluded immunological response. So PD-L1 is present at the periphery of the tumor, but not inside the tumor. And some other tumors have this intermingled response. So the theory would be that these tumors will not respond. These tumors could be encouraged to take on board immune response, and these tumors are the most the better ones at providing response, but that's not really necessarily entirely the same. They're always the same. Together with the immune response, also the tumor cells may express PD-L1, and these are two examples of tumors that express PD-L1, membrane staining. This is partial, and this is kind of quite diffuse. In lung, while in other tumor types, tumor expression of PD-L1 seems to have been quite important in selecting patients. In lung, has never really been very prevalent. The immune response has been important in selecting patients. In lung, has not been very prevalent, and only the tumor expression has been the target of our attentions. I don't know why this is. It could be because lung was one of the first tumor types that people looked at, and these were the measurements we were making. Or it could be that in lung, this is a very important factor, the production of PD-1, the expression of PD-L1 by tumor cells. So in immunohistochemistry, we have a large number of antibodies against PD-L1. Some of them are actually part of validated companion diagnostic assays, which have approval by the regulatory bodies for this type of things. And you can see here that these antibodies, they hit different parts of the molecule. This is a mock-up of the PD-L1 molecule, and some of them are extracellular domains, some of them are intracellular domains. The molecule actually has differential splicing, so we are not entirely sure that all the cells have all the epitopes that this antibody hit, because they could be absent for differential splicing. And so we are not really entirely sure how equivalent these antibodies are in terms of predicting response. But the most important thing is that all these antibodies, especially in the companion diagnostic assay, they come with prescribed antigen retrieval, prescribed detection system, etc., etc. So these are really, they're all called PD-L1, but they're not all PD-L1. They're all different assays, it's the usual thing.
Differently.
Yeah, and unfortunately, for reasons beyond, logical comprehension, the four major anti-PD-1 and anti-PD-L1 drugs, durvalumab, atezolizumab, pembrolizumab, and nivolumab, they each had a different antibody and a different assay when they did the clinical trials, and often a different scoring algorithm. So they generated a large amount of confusion and discrepancy. And when you compare data, you need to watch out that you are comparing the same things. So in any case, the scoring algorithms are TPS, which is the old traditional percentage tumor cell positive. The combined positive score, which is a combination of tumor cell staining and immune cell staining. There is another scoring algorithm that looks only at immunocell staining, and then there is another algorithm which looks at both tumor cells and immunocells in sequence. So we had these four, and because we didn't have enough, Ventana came up with a fifth one recently, which is called TAP, tumor area positivity. If you want to read, you can read about it. Luckily, at the moment, doesn't affect non-small cell lung cancer, so we don't really need to talk about it. Because there were all these assays for all these drugs, and at the beginning, oncologists could use any of these drugs, all pathologists had a big panic and said, well, we can't possibly provide 4 different assays for the same tumor at the same time. This is mad. So blueprint studies started to be produced to see whether we can use 1 antibody instead of 3 or 4. And by and large, and you see the scatter here, by and large, 3 antibodies, they kind of said the same things, and 1 antibody was way out. And here are more of this blueprint study. The bottom line of this is that these 3 assays, 22C3, 28A, and SP263, are all relatively equivalent. Depends very much on the tumor type you're looking at and also the scoring algorithm, but in general, same. But SP142 is quite different. Actually, Adelina was telling me earlier on, SP142 is not really quite different, but in the context in which it's used, that is with the detection system and antigen retrieval, it does look different. So it's probably not just the antibody, it's the whole thing. And this is an example, this is not lung cancer, but it doesn't matter. You know, there are some cases where with 1 antibody you stain, and with the other antibody you don't stain, and it could be vice versa. It's not just, it doesn't go one way only. So what if we need to use, let's say, 22C3 and we don't have an autostainer? Well, you know, there are some studies that looked at how to put 22C3 on Ventana, for instance, and the web is full of these. So I don't want to incite you in rebellious behavior, but I think if you have to and you have to provide a test, you can do this also not using the prescribed autostainers. So to go back to, how are we doing for time? 24. So to go back to non-small cell lung cancer, and I put in UK in bracket because there are some geographical areas where the approvals are slightly different. But in general, we only use TPS, so tumor proportion score, percentage of tumor cells. And we have 2 thresholds, 1% and 50%. So something above 50%, traditionally called positive, and something below 1%, traditionally called negative, and then the one in between was called weak positive. That these are all terminology. And then depending on whether this was a squamous cell carcinoma or a non-squamous cell carcinoma, and whether it was used in first line, in combination, or in monotherapy, you use different thresholds. Fantastic.
And we have to say that now in adenocarcinoma or non-squamous, they try to find the targetable therapy well before, and then we end up with a little bit of tissue for PD-L1 studies.
Yeah. So afterwards, yes. Yeah. Okay, so that's the kind. Everything was going well until 2022 or so, where the trials of atezolizumab in monotherapy versus best chemotherapy in first line in treatment-naive patients came up, and it shows advantages. And unfortunately, he used the SP142 and a different scoring algorithm, the TCIC scoring algorithm. So for those of us that need to provide non-small cell lung cancer support for the oncologist, we will also need to think about SP142 and interpretation. But today is not about SP142, it's about the tumor proportion score. But just very briefly, these are some graphs that show that there is a certain amount of overlap and not complete overlap with other assays. So that really means you need to use SP142 if you want to use this treatment regime. And the FDA had approved in 2020 and EMA in 21. Okay, and this is an understanding, you either look at whether tumor cells stain, or if there are no tumor cells staining, you look at the immune cells. Is an area being okay? No, doesn't matter. So unfortunately now, the PD-L1 scoring system, these are the two, the one with the star, that are relevant for lung cancer. Okay, so back to TPS, which is our workshop. It's a percentage of positive tumor cells. What could be easier? It's not that, has not been that easy because there are some difficulties. So we recognize, we call a cell a positive cell if there is membrane staining. It doesn't mean only membrane staining, but needs to have membrane staining. It can also have cytoplasmic staining. If it has nuclear staining, and cytoplasmic staining and membrane staining is probably a dead cell, so probably you wouldn't want to count it. But you could accept nuclear staining and membrane staining, if you are convinced that the membrane staining is genuine. In the past, we used to say that PD-L1 did not localize to the nucleus, so therefore it was a non-specific staining. There are some papers that show actually that PD-L1 can go to the nucleus, so I'm not entirely sure that it's not specific. It doesn't matter. The important point is that any intensity of staining in the membrane, and doesn't need to be circumferential, is called positive cell. And that means even quite faint. And as we said, the thresholds are 1% and 50%. So the task is to understand whether there is less than 1%. We can't really do very much about it. Can be used in second line in combination with chemotherapy. Whether there is between 1% and 50%, there are some areas now where it is used in combination, or whether it is more than 50%, which means in most cases, the oncologist could use it in first line and could use it without chemotherapy. Yeah. What we think are the challenges of TPS in lung. So, first of all, is identify the target cells, the invasive carcinoma. Sometimes you could be fooled by a piece of a bronchial squamous epithelium that looks a bit dysplastic and you think is invasive. So you need to focus on invasive carcinoma. I think the challenge has been identify very faint and incomplete membrane staining, because this has caused some concern with pathologists. And the third challenge is the percentage of tumor cells near threshold. Okay, so identify invasive carcinoma. I think here pays off to learn what is the staining pattern of immune cells. So this is, for instance, a staining pattern of immune cells here, or lymphocytes. These are macrophages, and sometimes they can be convincingly looking like tumor cells. So, but you need to learn a little bit how these things stain. Obviously, tumor cells sometimes are easy to identify and sometimes are not. So this would be our first challenge. The second challenge is very faint membrane staining. So obviously nobody will quibble with anybody with this kind of intensity. That's nice.
Although this is also a bit because it has cytoplasmic staining quite a
There is a bit of cytoplasmic, but I think most of us will kind of feel that overall there is enough evidence that most of these cells, if these are indeed tumor cells, they looks like tumor cell staining, is indeed positive. And sometimes can be quite faint, but probably most of us will recognize that there is some faint membrane staining and we probably will be happy to call these
That one,
positive.
yes. Right-hand side, I
But
don't
this
know.
one, yes, this one now, you see, these are now the problems. The problem is that these lines become so faint where we actually asking ourselves, is this really actually an immunohistochemical reaction? So I know that those of you who's been following our PT testing know these things, but just for the others, I wanted to remind how we can be fooled by our brain interpreting colors and interpreting lines, because our brain wants to make sense of the world and will tell us, and we are convinced that certain things are certain things, but they are not. So this is a kind of famous now checkerboard illusion by Professor Edelson, who works at the MIT. I don't know if he still works there. Checkerboard, dark square, light square. There is an object here casting a shadow. The two square we're interested in, A and B. This is clearly the white square. This is clearly the black square. I made two circles, and I copied the staining, the intensity of this thing just by using the teardrop in our programs. So I made two identical circles. So if I put this on top of this, will be the same, because this is what happens, it will be the same. So I put it here, same color, yeah? If I put this, that's the same circle. If I put this over here, it will clearly be darker. That's what our brain tells us, but this is what happens, So here it is. It's not a trick. It's real. Yeah, I haven't cheated. Yeah. So this means be careful, because sometimes your brain tells you that there is a line with staining and there is no line of staining. So when you interpret the sections, please remember that what you're looking at needs to be credible. So your membrane staining needs to be something that you as a pathologist can believe in. So don't be fooled by shadows. Okay, so the third challenge would be calculating the percentage of tumor cells near threshold. And this is a challenge in whatever we do, HER2, everything is a challenge. So while I don't want to dismiss the problems around the threshold, I wanted to explain how do we get to thresholds, because I think that's relevant. Okay, so ROC curves. ROC curves is how the statisticians and the oncologists tells us what threshold to use to select patients. So this is a typical ROC curve. It doesn't matter what these axes are. It's just to separate a population of responders from non-responders in this particular thing. And then you join the base, and then you go and have a look at what is the maximum distance from the base, and this value, I think I did something wrong here. Okay, I did something very wrong. Yeah, so just a moment, we'll escape this because I don't like imprecisions. That's better. Let's go back to where we were, and we get our okay. And so we identify the point, and then we say, this is the point of maximum separation. This is my threshold. My threshold is 0.223, but then probably somebody will say, let's call it 0.2, we identify. But what I wanted to tell you is that actually there is very little difference between this point and this point. And this point would be 0.3, and this point would be 1.5. So my point is that around the threshold, it's not as if you're falling off the cliff and then you have no responders whatsoever. There are still a significant number of responders, maybe not as good as the threshold, but still.
Plus, we don't know, we test a single piece of tissue.
Yeah. Also, Adelina, the real issue is that these are fantastic ROC curves. These are the real ROC curves that these people work with. It's like, I don't know. So what I want to say is that while I understand that it's important to be precise, that it's 1% or 1.2% or 0.9%, also don't get yourself a a heart attack to trying to decipher it, because there is an element of uncertainty in all this. And even when we identify the threshold, it's not that everybody responds, 40% responds, okay, So sometime well, we often encounter this position and we say, well, this is going to be really difficult to know exactly if this is just above or just below. But I can tell the oncologist that it is difficult, and I can tell the oncologist I'm going to regard this as positive, but understand the limitations of my assessment. Yeah. Okay. Running a little bit late, I'm very sorry. So talking about on-slide controls, this is important. Tonsils and cell lines. So tonsils were developed together with these tests, and they look like this. And they are very useful because they're very useful when you are assessing immune cells, because there is a wealth of immune cells here. But also there is a wealth of staining intensities. So if we look at higher power, these are the crypts, these are the interdigitating dendritic cells that are staining here with all these spikes. And these are the macrophages in the germinal centers. And then there are these interfollicular T cells with dot-like positivity. So this gives us a range of staining in immune cells. Note that the squamous epithelium is negative when there are no dendritic cells in it. How do I get the marker here again?
Yeah.
Oh, here, very good. Thank you. And because of the ranges of intensity, this is quite a useful and accepted on-slide control. You don't need to put the whole tonsil in here. You just put an area of it.
I have to say those, I think they're from 142 example. I mean, it's similar with 263.
263, yeah.
But probably not as intense, not this.
Yes, so
dark.
Yes, because 142 has got a very high contrast and 263 has got a lower.
But the distribution is staying.
And so in general, when you look at the tonsil, the intraepithelial dendritic cells very strong, macrophage in germinal center, lymphocytes, a paranuclear dot, and the squamous epithelium has got no staining. So that's how you navigate the tonsil. Remember that processing tonsils is also important. This would be an ideally stained tonsil. This is a rubbish one. And that's not because we did something wrong. This is a normally processed tonsil as you would do in your routine. So if you do that, you don't get much staining. So you need to slice at 3 millimeters and fix the tonsil for 24 hours, then use long processing. Essentially, use a protocol you would use for lymph nodes in lymphoreticular pathology, and then you get the intensity. So the next bit that we use as on-slide controls are cell lines. The reason why we use cell lines is not much because we read a lot into it, but you can see that each antibody stains slightly differently, but you learn that whatever antibody you use, you need to have this pattern. So you understand the analytical performance of the test has been achieved according to your routine. And also you can compare very easily one slide to the other because these are all the same cell lines. The tonsil sooner or later finishes and then you need to find another one. Okay, just to remind you, threshold for positivity will depend on drugs and therapeutic modality, as we said, but also sometime on country-specific approval. And a few last slides, tissue selection. In lung cancer, most of us work with tiny amount of tissue because these are patients where probably you don't get resection. If it's stage 2 or 3, you don't get resection unless it's a mistake. And therefore, it's a small amount of either EBUS or transbronchial or thoracic biopsy. Tissue is very small. What happens if this is negative? Does it mean the tumor is negative? And maybe, maybe not, but we do know that the amount of tissue you retrieve has an impact because if the staining in the tissue is patchy and you sample an area that is negative, it is not really representative of the tumor. And this is just to tell you that in other organs, a small amount, a core biopsy versus the excision, determines that there are some inconsistencies, a significant number of tumors that are called negative, but they are not negative. And so, this is breast. In breast, we learned that if we find a negative PD-L1 on core biopsy, we will repeat on excision, because about a third more PD-L1 positive tumors will be identified. And you need to think about it is also on lung. And then this, we talked about this, TPS is for most applications, but if your oncologist wants to give atezolizumab monotherapy, you need to use the TCIC and the SP142. So how do we decide which test we do? Good question. And it's not our call, really, it's the oncologist's call. So we don't know. And that means we need to ask the oncologist the right question. And the best way to do it is that we give them a request form where we need to tell us. So our request forms look a little bit like that. And we ask them, which one do you want? And they can tick box if they want to. And the request form is a good way of communicating with your oncologist, because it focuses mind. You see, we ask exactly what you want, and please be prepared to update your request form as new indications arise. So this needs to be an evolving problem. What should the oncologists expect from us? I think that they really need rapid turnaround times. These patients are sick and they cannot wait weeks before they think about what therapy to do. So these are our turnaround time for PD-L1. We try to provide everything within 24 hours or 48 hours. Obviously, you don't manage for all of them. There may be weekends in between, but this is the type of service you need to start to provide to your oncologist. And then how do you report PD-L1? This is one of our report. You need to specify the tumor type, here it is, and you need to say what indication you are doing it for and what algorithm you use to assess. And then you really ought to try and provide a numerical result, not just positive or negative. And also try to give them interpretation in the context of the disease. What this patient would be eligible for in what, at what stage of the treatment. Good. Okay, so a little bit later than anticipated, we are on case studies. So this is now, Anna has prepared a poll for us, and then we will show you some cases that Adelina has prepared, and then we will vote and we will ask you questions. We will only assess TPS, tumor proportion score, and we'll ask you whether there is less than 1%, 1 to 50%, or more than 50%. So that's the first case. So on the left-hand side, you see the hematoxylin and eosin. This is clearly carcinoma. And here there is the staining with PD-L1. And Anna will put in the poll, and you need to vote, see what you think, and remember to press submit, otherwise we will be none the wiser.
Yeah, here I think you need to be very careful, because while there's obvious carcinoma, it's sometimes difficult to distinguish from the macrophages, the background cells. And this also has some pigment, which for 263 is not the end of the world in lung, the kind of black pigment we see. But with 142, that's
so that's a very interesting point. You see the staining here is quite mellow. It's quite brownish mellow.
Brown, golden.
Golden. And instead the pigment is quite black. So the contrast is very marked. So we wouldn't make a mistake. Okay, so here is the result. So most people thought this was above 50. A few people said between 1 and 10. I'll close this guy. What did you think, Ade? Because you chose these cases.
Almost, if not 100% probably.
Mm-hmm.
Now we can go the other way around and have a look at the cells that are not staining in between and maybe compare the size, because these are much smaller, the nuclei.
Yeah.
They have very little cytoplasm. So I think they're all immune cells or stromal cells.
So I think there may be some macrophages staining a little bit more close to the lumen, but
It's possible,
they will not influence very much the percentage. Yeah. Okay. So
definitely
you're
over
happy.
50%.
Yeah. Shall we go to the next
Yeah.
case? No, next case. Okay, next case, this one here. Oh, Anna is very quick. Very good. Okay. So shall we vote?
Which one?
I don't know. You choose.
Let's do.
Yeah.
Let's cue the voting. Actually, I don't know. We need to move this a little bit. Can we?
Yeah. Okay, that's the result. So most people thought between 1% and 50%. Yeah.
Which,
what do you think?
this is what we answered, but if I think about it, okay.
So there is clearly definite membrane staining.
I
yes.
think at the glance we can say is just below 50%. I mean, recognizable staining.
Yeah.
And the rest is a bit equivocal, I think.
Yeah.
Maybe
But
cytoplasmic.
it's kind of a high percentage. This is not 1 or 2%.
Yeah.
What would you say? 25,
I think
30?
this is real.
Yeah.
I don't know how well it shows on the screen, but so I think it's at least 40%.
Okay, so are we kind of now in this particular case, obviously it's just a screenshot, there may be more of the tumor in the core. Are we kind of thinking we could have given 50% or not quite yet?
Yeah, it's borderline. I think I wouldn't, if someone called this 50%, I wouldn't.
You wouldn't worry too much. Yeah. It's a higher espresso, yeah.
And we have,
Okay.
quite a bit.
Okay. Next case. Let's give a little moment to think. Fantastic. Yeah, I agree. Okay, very good, very quick.
Very good.
Most people thought it was less than 1%, yeah? So I kind of, to be the devil advocate, could it be that there is membrane staining in some of these cells here, and therefore 1% rather than less?
I think we see some interface between the mucinous area of the cell, because if we look at the base, we have all these nuclei lined up and this kind of mucinous lipidic row pattern. But there's nothing in between these nuclei. It's only at the top that we see. And I think it's because of the mucus, and we see. And if we look carefully, they're gray compared to this area.
Where there is a bit
so
more
all
staining.
these cells that show sharp staining, they're macrophages. And especially whenever you see foamy cells, this kind of obstructive pneumonia kind of picture, you often have membrane staining that you can mistake at the glance. If you compare with the morphology well, then you shouldn't have any problems. But
very good, excellent. We do next case. This looks like an EBUS to me. Could have been a small cell carcinoma, no? But it's not.
I think it's large. Yeah.
Yeah.
Maybe.
So the nice thing about the TPS is that because you don't need the immune cells, you can also do it on cytology samples. So that's a great advantage for lung.
And we did have cases that we had cytologies tested at first, and because we didn't have enough tissue for other tests, then we've got the core biopsy, and we had pretty good concordance, at least of what I've seen, between cytology and
the core biopsy. So here, the opinion is split.
Yeah.
You know, is it below, is it above that 50% mark? And I can see why.
There are many intensities.
There are many things. So if you go on the stronger intensity, I agree. Is this 45%? Is it 50? But look, there are a lot more cells staining here more delicately. Kind of feel that probably we are over the 50% border.
Yeah, I think so. And even here, it's not complete. So you shouldn't expect seeing all this nice staining like HER2.
Exactly. This is not a HER2 staining. This is, any amount of membrane staining of any intensity will make the cell positive. So yeah, I would say you're right, more than 50. Oops. We can do a few more cases.
Okay. Very quick.
Very quick. Okay.
Good.
Okay, I think this is a really challenging case, Ade.
Yeah, I thought the same. That's why.
Maybe you did it on purpose. Let's see what people think. This is obviously a squamous carcinoma.
This was from a core biopsy, and it all looked very well differentiated like this.
So a lot of people said, the majority said, but a quarter thought it was just be 1% maybe. So a lot of people, that's zero. But you know something, I was going to ask you, is this invasive?
Well, it is, because the whole core, I had a look at it closely, and I thought.
So if this is invasive, do you not think that there is some membrane staining here? Or am I imagining
I think
it?
that's the challenge.
This cell looks positive to me.
Yeah, but is that some sort of...
This is very challenging. So is this acceptable membrane staining in these areas? Maybe we needed a slightly higher power to understand. So, we didn't talk about at what power you need to examine these slides. And the point of that checkerboard illusion was that we realized that if you start looking at the section at time 40, you call a lot of things positive, they're not positive. In reality, actually, you do see, in this case, you do see something here. I don't know the power. I think this looks like times 20.
This is 26 or something.
So at times 20, you do see something. You may or may not be sure it's membrane. Then you put a higher power time 40 and you think, okay, it's membrane staining. Or no, it wasn't membrane staining. So it is kind of to check rather than to make the diagnosis, I think.
Yeah, I think so. And I think we see some lines that are not actually staining, even at this magnification. So that's why, like Corrado said, we need to be very careful with. We still see some sort of shadows, interfaces.
Yeah.
And maybe this is real. This, I don't know. This, not sure it's membrane. It's
cytoplasmic, maybe, yes.
Here,
but I think there are some genuine cells that genuinely
now
stained.
this one, what kind of cell is this? Is this some sort of, if we look at the H&E, apoptotic kind of thing, or we can see we have edema here with some inflammatory cells.
Yeah.
So
okay, so I think this is a case where it exemplifies the fact that this is not just that we need to count. That this is, you guys need to engage the section, the slide with your pathologist on it and your experience to understand and reconcile whether the staining is proper or not. Most of the staining that you see here, this is all immune inflammatory cells. Okay, nice case. Next, how are we doing for time? Almost, last case. Okay. Can I score?
Yeah.
I must say that the H&E and the immunohistochemistry quite...
That was the point, actually, because we get so many tests on these things that sometimes there's definitely much more tumor on the right side than in the H&E. And this was actually a cytology with microbiopsies.
Right. You can see here, again, quite difficult. Is it just above or just under 1%? What did you think? I know I voted.
I think I'm with the majority.
I voted 1%, but yeah.
Because I think we can see definite. So these are tumor clusters, and we can see here that probably they're mostly composed of tumor. There are not many immune cells going on in, and these cells are large.
Yeah, they look like tumor cells. But some of these are not some of this is not membrane staining. This could look like cytoplasmic. This kind of thing is good. This is good.
Probably how many cells do we have here? Do we have
in here,
300.
yeah, maybe
And then
something like this. So you
we
need
need
3.
cells.
Okay, so we got 3 cells. Yes. Okay. So
So-
that's a good calculation. So Adelina has shown us, start to think about what the denominator is.
Yeah,
and
try
then-
and count 20 cells or something like this, and then try to understand how many
Yeah.
cells you have.
How did
in
you
your
get to
field.
300? You kind of counted the dots and then
I don't know.
Yeah.
I think I looked a little bit earlier, and it's
Yeah.
about 20
Okay.
cells like this.
So very good. I think we are now, we could actually escape here and go forward, actually. You have a few more cases. They're quite nice. We'll just talk over it. We won't do the poll because we would really like to have a few minutes for questions and answer. So this is a nice case. This looks like an EBUS, all these very rather pleomorphic goblet cells. There's quite a lot of positivity. Some of them is cytoplasmic, but I think some of it is membrane. I think it's probably just above 50% in this case. This is another case that looks like a low power. This is a resection or a wedge. I don't see anything at the moment, just a pigment, more pigment.
But if you go, this is actually staining.
Is
in
it?
fact.
Okay.
Yeah. So this was just, it wasn't more like a scoring case. It was just to point out these structures. Like here, I think they're reactive to the tumor, but be aware that you can see these bold structures like bronchiolar associated lymphoid tissue. And they can have dendritic cells, and they can stain similarly to the lymph node, what Corrado was showing to you later. So these are not tumor cells. They have nothing to do. This is, I think, is actually taken from that case with mucinous carcinoma.
Okay.
So I don't know.
Yeah. So this would be negative, really. The tumor cells are negative here.
Yeah.
Okay. So let's, we are on Q&A. You guys can unmute or you can ask questions on the chat. Anna's got something. Very good. I can't read.
If the percentage is falling between 1 to 50%, we are reporting it as such or reporting the specific percentage.
Okay, so pathologists don't really like that. They say, I will give you a bin 1 to 50, but I won't tell you exactly how much it is. I think it would be useful. I always find it useful because it tells the oncologist where we are. It says Corrado is quite confident because this is 30%. It's never going to be 50%. It's never going to be less than 1%. I know where I am. Or Corrado is telling me 45. I wonder whether if I give him a beer, if it will go up to 50%. I don't know. So it kind of gets more into this. And also, there are some oncologists that make some decisions also based on the amount of staining that we report. So I would say, if you feel you can, rise to the challenge, I would give the numerical.
It's like an exercise for yourself. And there are tumor types in which the oncologist only requests to see kind of, you give immunotherapy in any case, and then the oncologist wants to see if this tumor expresses PD-L1 or not.
That's right. And then maybe he will decide, but there wasn't a lot of positivity. I'm monitoring the patient. Maybe I'll go and if I don't see good response, I'll change to something else. So give him as much patients as you can for that.
And patients who cannot take chemotherapy, that's another, and the oncologist is mindful of that.
Is there another question? Thank you.
Okay. So if less than 100 cells, still say what percentage staining activity?
Yeah. So what's the minimum? So there is another question, which is really about what is the minimum number of cells required in order to get the test, assessed. So the providers of these tests, so if you look at the DACO interpretative guidelines, they say you need to have 100 cells. But, nobody has ever done any work to say why. They just say, because you have to have 1%, so I'll need to count 100 cells, whatever. But so there is no reason. And conversely, Ventana say 50 cells for exactly the same reason. No reason whatsoever. So there is an understanding that the fewer cells you have to count, the less precise this assessment is going to be. But are you going to say, because there are only 80 cells, I'm not going to tell you what it is. I think you probably are going to say is a little bit too little, but this is what I see.
Yeah, I think what we tend to do is like if the tumor tissue is PD-L1 negative and then we have too little tissue, then we're a little bit uncertain. What if we had a little bit more? And in any case, given that test, the patient would not be eligible for the respective treatment.
Yeah.
On the other hand, if you would have 50 cells in a sample and they all stain, then
so you could feel you could
even
provide that.
you can think there were, if there were 100, there would be 50%
Yeah.
at least.
Oh, Anna says the time is up. Are there any more questions quickly? No? Very good. Okay, so we draw this workshop to a close. Just to remind you that all these recorded educational sessions are available. We have a CADQAS YouTube channel. If you ask Hannah or Sarah or probably go to the website, you will find the links for that. The PT circulation for SP263 in TPS for lung is open today and will stay open until March the 10th. We will review the slides of the circulation on March the 12th at the same time. It's a Wednesday at the same time as today. And so thank you very much for everybody listen to and to have contributed to this workshop, and we may see you in 2 weeks' time.
Yes, thank you.